And we all know that acute pulmonary embolism is common, and prompt diagnosis and treatment can reduce the mortality from 30 to 2 to 8%. The initial approach to a patient of pulmonary embolism with suspected pulmonary embolism depends upon whether the patient is hemodynamically stable or unstable. A hemodynamically unstable patient is a patient with who may need massive pulmonary embolism with need for cardiopulmonary resuscitation, an acute PE with sustained hypotension less than 90 requiring vasopressor support, or a drop of systolic BP of 40 for 15 minutes, clear evidence of shock and organ hypoperfusion, pulselessness or persistent profound bradycardia with signs and symptoms of shock. Now, the initial approach is always in a suspected PE should be upon stabilizing while you are doing your clinical evaluation and running your definitive diagnostic tests. So the initial stabilization also includes providing oxygen to maintain oxygen saturation of 90, securing a peripheral IV access for fluids, as well as medications and vasopressors, looking out for signs of severe hypoxemia, hemodynamic collapse, respiratory failure. If you need to protect the airway, then intubating and putting the patient on mechanical ventilation. Simultaneously taking your detailed history and doing a physical examination. In a hypotensive patient, you can give an initial fluid bolus of 500 ml to 1 liter. And if the patient is still hemodynamically unstable, is hypotensive, then you start the patient after initial fluid bolus on vasopressor, and norepinephrine is the preferred vasopressor of choice. So when you have a patient with high suspicion, and you need to assess the clinical probability, so you look at the risk factors, you assess for risk factors, and in a patient with risk factors, you look at clinical features like profound dyspnea at rest. You look at the physical examination and look for you check for arterial hypertension. Patient may have tachycardia, tachypnea, and signs of right ventricular dysfunction. So assessing the clinical probability can be done by clinical judgment when you have the expertise available, or by certain clinical decision rules, which is your Wells score, your Geneva score, the PERC rule, which is the pulmonary embolism rule out criteria. So, along with the history that you take in detail, you assess, you initially resuscitate and manage the patient. You look at the clinical cues, and when you have a high suspicion, you're doing your workup. At the same time, with this clinical history and the workup, remember that you need to keep in mind while you're assessing the patient to rule out the contraindications for thrombolysis. So once you know that there is a high suspicion of pulmonary embolism, and you know that the patient is at risk, you give empirical, and there are no contraindications to anticoagulant treatment. Very, very important. You give the patient empirical anticoagulant as soon as possible while you're doing workup, while you're sending your essential tests, and while you are, planning your patient for investigations. So low molecular weight heparin in a hemodynamically stable patient who do not have renal insufficiency, unfractionated heparin for hemodynamically unstable or in anticipation of a potential need for thrombolysis or embolectomy, and fondaparinux is another drug for empirical anticoagulant treatment. Various drugs and their dosages, and they are all equally efficacious for anticoagulant treatment. Then you order investigations. So your basic investigations, of course, include your basic blood workup along with sending the basic bleeding clotting profile. ABG might be normal in about 20%, but about 70% of the patients are hypoxemic. Then you also do chest X-ray, ECGs, BNPs, troponin, as well as the D-dimer. Now remember, neither of these tests are sensitive nor specific for the diagnosis of pulmonary embolism, but they can help you to determine prognosis once the diagnosis is made. And D-dimer is the most useful when it's used in conjunction with clinical suspicion to facilitate clinical decision making for imaging. Now, ECG can be normal in about 15 to 30% of patients. Sinus tachycardia is one of the most commonest findings that you would see on an ECG. There are various arrhythmias that are seen, and S1QT33, which is considered it's very specific for acute pulmonary embolism, as this ECG is showing, is also associated with poor prognosis. Now, chest X-ray can be normal in about 12 to 22% of patients. And there are various signs which are seen on chest X-ray, like pleural effusion, elevated diaphragm, Westermarck sign, which is peripheral sharp demarcated lucent areas. These are basically because of focal or diffuse oligemia, as seen on both these X-rays. One is showing focal, one is showing diffuse. Then Hampton's hump, which is a shallow wedge-shaped opacity in the periphery of the lung with its base against the pleural surface and apex. It represents basically pulmonary infarction, if you can see with these arrows on both these X-rays. Then Fleschner's sign is because of dilated central pulmonary artery due to presence of a massive embolus or pulmonary hypertension, as you can see here. Then there is another sign, which is the Pala sign, which is appearance of a enlarged pulmonary artery. And as you can see, there is the sausage shape of the pulmonary artery, if you can appreciate on these X-rays. This is your Pala sign, again seen on a chest X-ray in case of pulmonary embolism. So various signs are also seen, but they are not very specific. I mean, they are seen in cases of pulmonary embolism, but they are not always seen, and they're not always very, chest X-ray is not very helpful always. So when you have a patient with high probability of pulmonary embolism, the gold standard for investigation remains your CT, multi-detector CT pulmonary angiogram. And if you look at the CT pulmonary angiogram, you can see the characteristic bilateral embolus is a characteristic saddle-shaped embolus in this CT pulmonary angio. Then another sign that you see on CT pulmonary angio is your polo mint sign. If you could appreciate a polo mint here, and you see that there is contrast around the embolus. So this is another sign which is seen in patients with pulmonary embolism. Railway track sign, because of the presence of embolus, the contrast is flowing on both the sides. So this is another. So these are signs which are associated and seen in patients with pulmonary embolism. There are various pleural and parenchymal abnormalities also which are seen in patients with pulmonary embolism, like the presence of pleural effusion, presence of infarcted areas, then the reverse halo sign, which we commonly associate with aspergillus, but it can also be seen in the areas of infarction, which appear sometimes like consolidation with air bubbles in between. So the bubbly consolidation sign and the reverse halo sign are also seen in patients of pulmonary embolism because of presence of the infarcted areas. Then there can be certain artifacts like the air artifact and the flow artifact, which can look like the embolus. Then dual energy CTPA, it's available in limited centers, but it has been done. Now, this investigation basically helps you to identify and see the areas of hypoperfusion. So as you can see on these scans, these. Now, if you cannot do a CT pulmonary angiogram, which is the gold standard, if your patient is not shiftable, is hemodynamically unstable, then what you can do? The investigations are echocardiography, preferably a transesophageal echo, and a lower extremity ultrasound. Now, there are various signs which are seen on an echocardiogram of a patient with pulmonary embolism, like enlarged right ventricle, the McConnell sign, which is the regional wall abnormality with sparing of the right ventricular apex, and flattened intraventricular septum. There can be presence of a right heart mobile thrombus detected in the right heart cavities, the decreased TAPSE in M mode, which is less than 16 mm. So these are the characteristic findings on echo in a patient with pulmonary embolism. So remember, no echocardiographic parameter has sufficient sensitivity to allow its use for diagnosis of pulmonary embolism in stable patients. But in shock states, the absence of RV dysfunction rules out pulmonary embolism as an etiology. Compression ultrasound, another modality, is been used for proximal DVT in a symptomatic patient or in an asymptomatic patient who has contraindications to CTPA So this is considered sufficient for diagnosis of pulmonary embolism in these patients. Now, VQ scan, when there is a contraindication for CT and there is a high clinical probability, like your patient has contrast allergy, has CKD, is morbidly obese, or in a pregnant patient when the chest X-ray is normal, then VQ scan is the modality of choice. Now, patients with a low pretest probability and a normal low probability VQ scan have the chance of less than 4% of having pulmonary embolism, whereas a patient with high clinical probability and a high probability scan have a 96% chance of having a pulmonary embolism. So that's how significant a VQ scan can be in specific cases. This is showing you a normal pulmonary ventilation as well as an abnormal pulmonary perfusion seen on a VQ scan. Now, MRI, although is coming up and we've been talking about in this series about the importance of MRI, but it is insufficient. It has insufficient sensitivity and a high rate of technical inadequacy when it is used for pulmonary embolism. So, MR for patients suspected of PE in whom you cannot do your CTPA or VQ scanning. So if you see these coronal and axial cuts, this is on a CT and this is on an MRI. So you can appreciate that even without contrast, even on these on the left side, you can appreciate the embolisis if they're clearly shown with the arrows. So MR angio can be useful in patients, and even without contrast, you can appreciate the presence of the pulmonary embolism. Now, contrast enhanced pulmonary angiography used to be a gold standard, but now it is only reserved for rare cases in which catheter-based treatment is indicated. Now, something about D-dimer. So, a negative high sensitivity D-dimer rules out PE in low and medium probability patients, whereas a level of more than 500 in low or medium probability, you must do a multi-detector pulmonary CT angiogram to rule out pulmonary embolism. And remember that there are certain cases wherein it can be high, like in cases of patients with malignancy, pregnant women, hospitalized patients, and elderlies. So then treatment, you must consider thrombolysis in hemodynamically unstable patients. So this was a case of a 75-year-old female with um, road traffic accident with multiple fractures, and she was hemodynamically unstable and hypoxic on presentation. So when you look at her CT pulmonary angiogram, you can see the same saddle-shaped thrombosis on both the sides. Again, on the coronal section, if you can appreciate on the right side, there's presence of a thrombus. So you need to consider the patient for thrombolysis. The only potential harm in a patient with thrombolysis is disabling or fatal hemorrhage, including intracranial bleed, although not very common, but this is one of the major complications if it occurs with thrombolysis. Now, treatment algorithm for patients for the use of fibrinolytics. If you have a patient with probability of massive pulmonary embolism, there is evidence of shock or respiratory failure. You've given the initial anticoagulation and there are no contraindications. Remember, you must always rule out contraindications in the very beginning when you're evaluating your patients. The drug of choice is elliptilase, 100 milligrams given intravenously over 2 hours. Another case, 72 years old patient with diabetes and hypertension as comorbidities, although was hemodynamically unstable, but on echo had RV enlarged, small LV, TAPSE was 13, pulmonary artery systolic pressure was 48, and as you can see, there is NT-proBNP was 1500 and TROPI was positive, so it had signs of myocardial necrosis as well as RV strain. And when you look at the CT pulmonary angio of this patient as well, you can see characteristic thrombosis on both the sides. Again, on this coronal cut, you can see the presence of thrombus. So Even in a patient who is hemodynamically stable, but has evidence of moderate to severe RV strain, RV dysfunction, and evidence of myocardial necrosis, like your high NT-proBNP, high positive tropi, with no contraindications to fibrinolysis. The drug of choice is LT-place. Again, like I said, 100 milligrams IV over 2 hours. So the thrombolytics that are used are streptokinase, urokinase, and alteplase has been more commonly used, and it has been associated with best clinical outcomes. So in a patient who's hemodynamically stable and there is no evidence of, like I said, shock or respiratory failure, submassive without RV strain, then you give these patients heparin anticoagulation. This is your hemodynamically stable patient. So if there are contraindications to, or there is a failed thrombolysis, then you can do catheter-directed thrombolysis or percutaneous mechanical thrombectomy. This is another case of a patient, a 21-year-old gentleman who was apparently well, had sudden loss of consciousness, which resulted in a fall in the bathroom, and his echo had a dilated RARV with severe pulmonary artery pressure. Pulmonary artery hypertension, as you can see, the pressure is very high, 70, and this was his CT pulmonary angiogram, and you can see that there is presence of a characteristic embolus. So this patient was initially first received thrombolysis, which did not stabilize the patient. So thrombectomy was done, and post-procedure, he was given IV stylase or elliptilase at 2 mg per hour for 24 hours. As you can see here, both the pulmonary arteries and the elliptilase is being given at 2 mg per hour. So he clinically eventually improved and was switched to anticoagulation with oral anticoagulant. And during follow-up also, he continued to improve, was clinically better. In his investigations during workup, it was found that he had a homocysteine level of 153 and he had protein CNS deficiency. All other screenings were negative. So if there are contraindications to, or there is failed thrombolysis, then surgical embolectomy is the treatment of choice. However, it's a very complex procedure. It requires expertise. It's done in very limited centers. Then IVC filters is recommended in patients with contraindications to anticoagulation or with active bleeding complications, recurrent acute pulmonary embolism despite therapeutic anticoagulation, and bleeding while on anticoagulants. Long-term anticoagulation. Now, usually the preferred drugs for long-term anticoagulation now these days, usually the oral anticoagulants are preferred. And when there is a first episode of PE with reversible risk factors, the duration of anticoagulation is 3 months. With irreversible risk factors, it is indefinite anticoagulation. Now, complications of pulmonary embolism is basically your chronic pulmonary thromboembolic pulmonary hypertension, which develops in the first 2 years in about 1 to 5% patients among the survivors of acute pulmonary embolism. So it is seen in about 1 to 5% of patients with pulmonary embolism. And it is defined by at least 3 months of effective anticoagulation, a mean pulmonary artery pressure of more than 20 millimeter of mercury with a pulmonary capillary wedge pressure of less than 15, one or more mismatched segmental or larger perfusion defects detected by ventilation perfusion lung scanning, or CTPA, and thromboemboli without pH is chronic thromboembolic disease. Risk factors for CTEPH are basically younger age, previous history of PE, large perfusion defects, high clot, more than 50% clot load, unprovoked PE, systolic pulmonary artery pressure of more than 50 at the time of diagnosis of acute PE or at the time of hospital discharge after acute PE. And adequacy of anticoagulation and standard risk factors for thrombophilia were not there. How do you recognize these patients? Unexplained decline in the functional status, exertional dyspnea disproportionate to the findings, features of RV dysfunction, hemoptysis, and a previous history of PE. ECG there are various findings which are seen basically of right ventricular hypertrophy. The sensitivity is about 55 and specificity is 70% for detecting significant pulmonary artery hypertension on an ECG. VQ scan, the essential test for diagnosis of CTEPH. Normal VQ scan excludes both acute and chronic pulmonary embolism. Now, this is a pulmonary angiography, which is the gold standard done for CTEPH patients. And as you can see here in both of them, there's a presence of an organized thrombus, and there is complete cutoff beyond this. Again, after the embolus, if you can appreciate here with the arrow, I don't know whether you can see or not, there is peripheral pruning. There's a clot over here as well. So CT pulmonary angio is what we do these days, even for these patients. It is accurate, it is non-invasive. When you compare it to VQ scanning, it is non-inferior. It identifies more emboli without necessarily improving the outcome. So the CT findings in patients with CTEPH, you would see mosaic attenuation. Why? Because of the area of the presence of the embolus, there is oligemia, which appears like this. Again, mosaic attenuation seen on different coronal, axial, and sagittal sections from a patient. Then there can be a very enlarged pulmonary artery, which is another finding in CTEPH patients. And this was one of our cases. This patient has been there for over 10 years, is a case of CTEPH. If you can appreciate here, in the beyond the left main pulmonary artery, there are further branches of the pulmonary artery on both the sides, right and left. So you can see here, there is reduced perfusion over here. There is narrowing as well. Again, on the coronal cut, you can see mosaic attenuation. Then you can see some areas of some calcification within the thrombus, which is also one of the signs which is seen in patients with CTEPH. So the radiological features that we also see are in CTEPH patients is intravascular web. If you can appreciate this blackish here between an arterial retraction, this thin line over here, then flattening of the intraventricular septum, RV hypertrophy, dilated bronchial arteries, these white dots basically, and this is generally because of development of collaterals over time. Dilated pulmonary artery, you can see there's a enlarged pulmonary artery. So bronchopulmonary collaterals develop in these cases. All these white dots that you can see are because of development of the collaterals. We did speak about the dual energy scan, and this has been seen. This has been helpful even in the CTEPH patients, and it shows you the areas of hyperperfusion. So in patients, the diagnosis of CTEPH involves patients with unexplained pulmonary hypertension or pulmonary hypertension and a history of embolism. You do a VQ scan, which is normal, and so you rule out. But if there is an indeterminate or multiple perfusion defects, then further imaging with CT, MR, angio, or pulmonary angiography should be done. It is a multidisciplinary approach. It requires a specialized center. It requires expertise. It requires a specialized surgeon as well. But these days, we generally do an echo and a CT pulmonary angiogram. An echo, 2D echo would tell you about the pressures of the pulmonary artery, and CT pulmonary angiogram, we've seen the features, is enough to diagnose patients with CTEPH. Now, what do you see? I've shown you some X-rays and CT scans in a patient of acute versus chronic PE. The findings on the pulmonary angiogram in an acute and chronic setting would be: in acute, you would see a central or eccentric filling defect, while as in a chronic PE patient, you would see peripheral and concentric shaped filling defects. Then collaterals in, of course, acute case would be absent, but we saw those tiny dots. In chronic case, you would see bronchial and non-bronchial systemic artery dilatation. Parenchymal signs, I did show you areas of pulmonary infarction, reversed halo sign can be seen. In chronic cases, you would see pulmonary scars. Cardiac MRI is in cases of CTEPH is considered as a gold standard for assessing right ventricular size, volume, and function. Pharmacotherapy for CTEPH patients, the essential therapy And of course, requirement of lifelong anticoagulation. Remember to keep the target INR between 2.5 to 3.5, but this is very individual, it's patient based, and it has to be individualized depending upon the underlying history, of patient's presentation, age, and associated factors. Medical therapy for CTEP patients is indicated in inoperable cases, comorbidities that contraindicate surgery, those with residual pH, or as a bridge to surgery. And Riociguat and Macitentan are the only drugs with proven evidence for medical therapy in your CTEP patients. Surgical treatment is with pulmonary endarterectomy. It requires expertise. It's a complex procedure, only available at limited centers. And of course, lung transplant, but it is high mortality and morbidity, and it is also associated with lower survival rates. If you can't do surgery, then balloon angioplasty is the next possible management for your patients. So, to summarize, pulmonary embolism is a common preventable cause of hospital death. Mortality can be as high as 30% if untreated, and it can be reduced to 2 to 8%. Clinical presentation is highly variable and non-specific. Risk stratification, stable versus unstable, your clinical criterias, they guide you to diagnose and provide you a therapeutic approach. Multi-detector CT pulmonary angiography is the gold standard. Echocardiography and compression ultrasound is the crucial bedside alternatives for hemodynamically unstable patients. D-dimer and VQ scan in selected patients. Algorithmic approach combining clinical probability and imaging ensures accurate and timely diagnosis. Immediate anticoagulation, if pulmonary embolism is suspected and no contraindication, low molecular weight heparin is the preferred choice in stable patients. Thrombolysis is indicated for massive PE, unstable, as well as submassive pulmonary embolism patients. Long-term anticoagulation, oral anticoagulant drugs are preferred over vitamin K antagonists. And you need to monitor your patient for chronic thromboembolic pulmonary hypertension. It occurs in about 1 to 5% of survivors, defined after more than 3 months of effective anticoagulation. In patients who have the pulmonary artery pressure of more than 20 and a pulmonary capillary wedge pressure of less than 15, persistent mismatched segmental perfusion defects on VQ scan, and it represents progression to chronic thromboembolic disease with pulmonary hypertension. The diagnosis, various modalities are available. VQ scan is the most sensitive screening tool, but CTPA, MRA, and DSA confirm the presence, and right heart catheterization in limited cases to assess hemodynamics. Management with long-term anticoagulation therapy, medical therapy with riociguat. Pulmonary endarterectomy is the treatment of choice in operable patients, and balloon pulmonary angioplasty in inoperable or patients with residual disease. Thank you.